Good afternoon, and welcome to today's Recovery to Practice webinar titled Shared Decision Making, Changing the Conversation. My name is Melody Reefer, and I'm your host today. After some housekeeping and a short overview of Recovery to Practice, we'll begin today's presentation. On behalf of the Substance Abuse and Mental Health Services Administration and the Recovery to Practice team, we'd like to welcome you and thank you for joining us today. We have about 80 or so people on the call at this point, and we do expect the number to grow as we go through the conference. I would like to also thank our presenters, Neil Corson and Jesse Higgins, for sharing their knowledge and experience with us today. At the bottom of your screen, you'll see a Download Materials Here box where you can download our presenters' bios as well as a PDF of presentation slides. At the end of the session, you will also be able to download a certificate of attendance that you can use to apply for continuing education credits for your specific professional association. This webinar has been pre-approved for continuing education hours from NAADAC, the Addiction Professionals Association. To qualify for these continuing education hours, you must attend the full webinar, complete a brief quiz, and the webinar evaluation. More information on this is at the end of today's webinar. At the completion of our webinar today, an opportunity to provide feedback will automatically open on your screen. Please take a few moments to provide us with your feedback. And finally, if you have registered for the webinar, you will receive an email link to view the archived recording. This link will also be available on the RTP website, where you will also find links to past RTP webinars. Feel free to share this information and those links with your friends. This webinar series is hosted by SAMHSA's Recovery to Practice initiative. The overarching goal of this initiative is to improve the knowledge and ability of the behavioral health workforce to use recovery-oriented practice every day. But what do we mean by recovery-oriented practices? Well, in 2011, SAMHSA released a working definition of recovery and a set of guiding principles that incorporate aspects of recovery from both substance use and mental health conditions. SAMHSA's working definition of recovery in behavioral health is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. The 10 principles of recovery shown on this slide, along with the 4 major dimensions of recovery, those being home, health, purpose, and community, form a solid foundation for developing recovery-oriented lives and for building recovery-oriented services and systems necessary to support them. SAMHSA's Recovery to Practice initiative helps you turn these principles into recovery workforce practices. RTP offers a set of discipline-based curricula to promote understanding and uptake of recovery principles and practices. Developed by these 6 professional disciplines for educating their membership about recovery in behavioral health, these materials are adaptable for use by other disciplines and organizations seeking resources to build a recovery-oriented workforce. Links to these curricula are available at SAMHSA's RTP website. RTP is constantly expanding its discipline focus to embrace multidisciplinary services and integrated settings. Those of us who work in behavioral health or integrated healthcare organizations have opportunities every day to promote wellness and recovery. We can powerfully communicate hope for recovery and the value of self-care and wellness just in how we approach our work. RTP can help you strengthen your recovery-oriented practice through free webinars, newsletters, and conference-based educational events. Today's webinar will provide an overview of shared decision-making as a concrete example of recovery-oriented behavioral health practice. The presenters will demonstrate how the adoption of shared decision-making in an integrated care practice, working with individuals with opioid use issues, anxiety, and depression, contributes to improved communication and a more collaborative care. Participants will learn how shifting from giving information to collaborative dialogue impacts relationships and outcomes for all involved. I'd like now to introduce our speakers for today. Neil Corson, MD, is a family physician and geriatrician with 20 years of practice experience. He graduated from the master's program at the Center for Evaluative Clinical Sciences at Dartmouth in 2002. He leads a number of quality improvement programs for Maine Health, an integrated delivery system in southern and central Maine. Dr. Corson was first exposed to shared decision-making as a practicing physician in the 1990s when his office participated as a site for the prostate patient outcomes research trial. He leads the shared decision-making program at Maine Health, which was funded from 2009 to 2015 by grants from the Informed Medical Decisions Foundation and from the Center for Medicare and Medicaid Innovations. He also serves as a consultant to HealthWise, a developer of shared decision-making and patient education materials. In this role, he helps healthcare organizations develop implementation plans for shared decision-making. Our second presenter is Jessie Higgins. She's passionate about improving patient and medical provider access to behavioral health expertise through integration. Jessie is the Director of Behavioral Health Integration at Acadia Hospital in Bangor, Maine. An Acadia provider since early 2010, Jessie has practiced consultative psychiatry and primary care at Eastern Maine Medical Center since 2011. Acadia's BHI providers improve patient and medical provider access to behavioral health expertise by using a consultant liaison approach to integration. In addition to her training as a psychiatric mental health nurse practitioner at the University of Southern Maine, Jessie has earned a graduate certificate in primary care and behavioral health integration from the University of Massachusetts Medical School in 2013 and a graduate certificate in health policy and management from the University of Southern Maine in 2016. Jessie is an active member of several hospital and community committees in which she helps shape policies that encompass compassionate, collaborative, and whole patient care. We're very pleased to be able to bring to you such high-caliber experts. Dr. Corson, I'll now turn the webinar over to you.
Thank you. I guess good morning or afternoon, depending on where in the country you are. My job for the next few minutes is to review the basics of shared decision-making for you. I want to start with a definition. There are many out there, and this is the one that I've been using because I think it captures the most important characteristics and principles of shared decision-making. So it is a process between individuals using services and their clinicians. So it is about a conversation or a dialogue. That's one important thing. It engages the individual in decision-making to the extent that that person desires. I think it's important to point out that historically our approach to decision-making in healthcare has generally been that the clinician makes or at least recommends decisions. So I think it's important to recognize that we want to help the individuals who we're serving to become more active participants in making decisions about their health, and that may require some support. The current situation may not make it easy for people to do that. Once we've engaged somebody, we want to provide that individual with current and unbiased information about alternatives, what alternatives are available to them, and then understand what's important to them so that we can facilitate the incorporation of their preferences and values, otherwise thought of as what are their goals in treatment or what's important to them, so we can incorporate that into the treatment plan. So that's how I would have you think about shared decision making. So hearing that definition, we have a poll question for you. And that poll question is, are you participating in shared decision making now in your practice or in the way you provide care? And we'll watch the answers. Most of the people who have answered, more than 80%, are saying that they are currently participating. And it continues to be about 80, ranging between 75 and 85% as more people answer. Thank you. So I want to talk about a few key research studies that provide the foundation for why shared decision-making is drawing a lot of attention these days. And it really addresses one thing that I commonly hear when I speak to groups of clinicians and describe shared decision-making, not unlike the poll, is that people say, we're doing that already. We understand what shared decision-making is, and we're doing that already. I can't comment in general about what happens behind the door between a clinician and the person they're serving, so I can't either agree or disagree when somebody says that. But what I've been doing is pointing out what the literature says. So one of the important studies was called the decision study. Somebody was very good at algorithms, not algorithms, you guys know what I mean, to come up with decisions for the study name. So this was a survey of people who were initially asked if they had made one of 10 common decisions over the past year. Some of those decisions had to do with cancer screening, some had to do with elective surgery, and others had to do with medication choices for chronic conditions. Anybody who had made one of those 10 decisions was included in the study, and there were more than 3,000 patients, therefore, involved. The results of this study showed that, in general, clinicians were very likely to describe the potential benefits of any recommended treatment, more than 90% of the time, but less than half the time, in general, was there discussion of the potential risks or cons of those decisions. In the case of back and hip or knee replacement surgery, people reported that the clinicians did better. It was above 50%. And in the case of spinal surgery, it was 80%. In addition, patients, those who were in the study, said that they were not asked about their preferences less than half the time, but the providers or clinicians express their opinion as to what the patient should do more than 3/4 of the time. So we're more likely to describe the benefits than the harms of options. We're more likely to tell than to ask is a good summary of what that study showed. Another study, given that clinicians tend to make the decisions, and we do so, I think, in a well-meaning way, that we understand the issues that are important to the patient, and therefore we, knowing their preferences, we can recommend the best treatment. This study, which was done by Karen Sapuka, a researcher at Mass General Hospital, showed that the truth may be otherwise. And this had to do with asking women and their providers about what was important when these women were facing decisions about treatment for breast cancer, to either have a mastectomy, removal of the entire breast, or a lumpectomy, just removal of the cancerous lump, which is generally followed by radiation. Sometimes either can be followed by chemotherapy. So you can see that in almost all cases, the provider's prediction of what was important did not match what patients said. Providers thought it was very important to women to be able to keep their breasts, but women did not report that as an important preference. Providers almost unanimously thought that living as long as possible was important to women. Again, that was not as highly rated by women. Similarly with looking natural without clothing, excuse me, and while providers did not at all think it was important to women to avoid using prostheses if they had a mastectomy, some women, a substantial percentage, did think so. So in general, without asking, providers are not particularly good about predicting what's important to their patients. It means we have to ask. Finally, the issue of having a shared conversation about decision-making is a challenge to people. And this was a focus group study. It was done in Palo Alto, California, with people who got their care through the Stanford University Medical System. And what this showed that I think is important to point out is that even in a community that is highly educated and certainly socioeconomically above average, people are hesitant to ask questions of their providers. They feel compelled to defer and don't want to be seen as difficult patients. And perhaps not surprisingly, they recognize and identify that physicians can be authoritarian. So that really reinforces and underlines the importance of inviting people to be actively participating in their decision-making. So as we talk about shared decision-making, one thing that we need to talk about are decision aids. And this is a definition of decision aids. They come in a variety of formats. They're designed to help people become more actively involved in decision-making by making sure they understand that there is a decision, there's more than one reasonable option, that information is provided about those options and the impact of various options, so both the benefits and the risks. And then a decision aid also helps an individual think about what's important to them in relation to the decision they're making. Watching a decision aid by itself is not shared decision-making. The shared decision-making is the conversation that happens afterwards. But this really helps a person be prepared to have a conversation, to understand the issues, and to have some time to think through those issues. I'm going to show you a whole variety of types of decision aids just so you can see what's out there. my focus today is to talk about decision aids that are available publicly that will not cost anybody any money, at least in terms of obtaining them, because some of you out there may not have access through whatever organization you're part of. The good news is that when I last checked, 4 of the 5 largest developers of decision aids do make their tools available without charge. I will have links at the end to websites for all of these organizations. SAMHSA is also working on developing decision support tools, and I'll show you one example of those among my examples. These are some shots of a few decision aids that have been developed by the Agency for Healthcare Research and Quality that are specific to decisions about behavioral health related treatment options. And you can go to ahrq.gov. You'll see the link towards the end. These come from the Mayo Clinic and are available at their shared decision-making website, also on the bottom of the slide. These are designed to help people make a decision with their clinician if they're considering antidepressant medication. And you can see they're organized by addressing different aspects of what might be important to somebody when they're thinking about antidepressants, whether it's impact on weight, on sleep, on sexual function, what they cost. And so they're designed to help a clinician and the person they're working with to compare the various options and identify the one or more options that seem to best meet the preferences of the person. The next are similar cards. These come from a behavioral health organization in California. They developed them themselves, and these are designed to help youth of transition age make decisions about antipsychotic medication. So you can see, similarly, there's various ways that the medication options are compared and contrasted so that a person can think about what's important to them and make a decision. This is an example of the kind of decision support tool that SAMHSA is working on, and it describes this particular view, describes side effects, common side effects among a variety of antipsychotic medications. This, while it's about a decision related to cancer screening, is an example of what's called an option grid. It's another way of summarizing the important parameters related to a choice. There is an option grid being developed related to depression treatment options, which compares medication and psychotherapy with a similar format. So there's been a lot of research about the use of decision aids in shared decision making and the impact they have on people's process of care. And this is a summary of a review by a group called the Cochrane Collaboration. It's an international group of scientists who volunteer their time to look at important questions in healthcare and summarize the evidence. This is actually the 3rd review they've done of shared decision-making and decision aid use in the past 10 years because they always redo a review when there's new research and new information, and there's a lot of research going on in this area right now. But what we know for sure, based on the research that's been done, is that when somebody uses a decision aid and a shared decision-making process, they have greater knowledge of their choices. They're more accurate in perceiving the risks, the benefits, and the harms of those choices. they're more comfortable with decisions, they participate more actively in the decisions, their decisions are more consistent with what they say is important to them, described here as expressed values. The patient rating of communication overall is better. Less people are undecided about the choices in front of them. And this gets somewhat controversial. It does appear that when people are fully informed, they are less likely to choose elective surgical procedures. I have to put the caveat that is in the short run because studies are generally not more than 1 or 2 years long. What we don't know yet, because studies haven't shown us this, is what the longer-term impact on choices which really have implications for cost of care will be. We don't know that yet. So that's what we've learned. Better decisions are made, and the decisions are more consistent with what people say is important to them. I want to briefly talk about one other thing that is related to, but not exactly the same as shared decision making. And that's a program called Choosing Wisely, which comes out of the American Board of Internal Medicine and Consumer Reports. It's a joint program. And it's about letting people know about healthcare procedures, tests, treatments that don't have strong evidence and that might therefore be overused. And it invites people to ask questions of their clinicians. The way the list of those things that might be overused was generated was each specialty society has provided a list of at least 5 things that they think evidence doesn't support. There's a total of more than 400 across all the specialty societies. The American Psychiatric Association has contributed, and all 5 of their Choosing Wisely issues have to do with the use of atypical antipsychotics, as is shown on this slide. They feel that atypical antipsychotics, which have considerable risk, are overused, and there's some things they want clinicians to avoid. I think for patients, a very important aspect of Choosing Wisely is the encouragement to ask questions, and a list of 5 important questions that really, if you think about them, comprise the kinds of things that might come up in a shared decision-making conversation. So the difference in Choosing Wisely is that we have a sense that the patient probably should avoid making these choices, whereas in shared decision-making, we feel that any choice, any option we offer is a reasonable one for patients. So that's Choosing Wisely, and thank you for this opportunity to talk to you about shared decision-making. I'll pass it back to Melody to hand it over to Jesse.
Thank you very much, Neil, for your information, and it's been helpful to have a concise overview on the foundational information about shared decision-making. And now I'd like to welcome Jesse and have you walk us through the application of shared decision-making in your practice.
Great, thank you so much. So my name is Jessie Higgins. They mentioned earlier that I'm the Director of Behavioral Health Integration at I work for a large psychiatric hospital, but I practice at a small family medicine practice. And all of this is interesting in application to the opioid epidemic. Here in Maine, we lost a record number of folks. I think it was 272 people to opioid overdoses last year. And we recently had a change in legislation that has sharply curtailed the prescribing practices of all outpatient providers, which has led to pretty rapid tapers of these medications for people who have been on them for many years. This has made many people who said shared decision-making cannot be done with opioids a little more willing to listen to how these conversations can go better. Okay, so let me click through. The learning objectives, just briefly, what we're looking at is working together with our patients, using all these principles that Neil talked about of shared decision-making and the principles of collaborative care. I do work on a collaborative care team. I'm a psychiatric nurse practitioner. I work with the folks from different disciplines to improve communication between all team members and really engage the patient and the family in the decision-making process. Now, it had been said that shared decision-making could not be done for chronic back pain, particularly for patients with a history of substance use disorder, because the general belief is that providers cannot prescribe high doses of narcotics, particularly here with the legislation, and that's what patients want. Patients want narcotics, we can't give it to them, so there can be no shared decision-making. And I guess I'm here to say that I truly believe the opposite is true. I think that shared decision-making is the key to addressing the opioid epidemic. The slide I have here talks about medical providers treating somatic symptoms of underdiagnosed and undertreated PTSD, anxiety, and depression with opioids. That's an inflammatory statement, and I know it. The SAMHSA actually pushed back a little bit and asked for research, and I did provide the moderators of this presentation with a reference slide explaining why I believe this to be the case. These patients with post-traumatic stress disorder are particularly vulnerable to prescription opioid use disorder. There's actually been some studies done that show changes neurobiologically in patients' brains, and they have been through a traumatic event, and still more changes in their endogenous opioid system when they have PTSD that make them really vulnerable to opioids. So continuing on, shared decision-making, I'm not going to go back and define this again. Certainly Neil talked about that and explained it. Talk a little bit about team-based care, because I think it is, there's a team-based care goes very nicely with shared decision-making. It's all about shared goals as a place to start. That often, we walk into the room as providers and we have goals for the patient. Neil talked about this at length, and the patient has different goals in mind. And there has been traditionally this authoritarian relationship with patients where we just sort of tell them what their goals are. And I've said before that if somebody had asked me before I did a large decision here around antidepressants, at the beginning of that pilot, I would have said that, of course I do shared decision-making. What kind of, horrible provider wouldn't do that? Of course I want the patient's voice in the decision-making. And, once I really implemented in an organized, thoughtful way, incorporating shared decision-making as a process in every patient visit, it really showed me that I was not doing that consistently. I was offering some of the choices, some of the time to some of the patients. And I was certainly tailoring that conversation depending on what I thought was in the patient's best interest. Principles of collaborative care, very similar to team-based care. I'm going to use these kind of as a foundation to talk about this more. Person-centered, really self-directed goals. We walk into the room, certainly there are some goals that patients will have in mind that may be different than ours. If it's a patient with a substance abuse history who's in pain, or a patient who's just used opioids in the past and found them helpful, and the provider's walking in thinking, I'm going to have this argument about opioids. There's a lot of kind of, charged energy in the room. I think we need to start with what goals we share, and often these are wanting to communicate clearly and honestly with between providers and patients, identifying patient strengths and provider strengths. Where can we work together? Where's our opportunity? Offering choices. Patients want choices, and promoting quality of life and ability to perform the activities that are important to patients. I would say that, the biggest complaint I hear from patients with a history of some sort of substance use disorder or period of substance overuse is that they feel labeled. They walk into primary care or into a medical appointment and they have that, big like red S on their forehead for substance abuse, and they know that half the options most people get are off the table for them, and that's not fair. And it's not. What we need to talk about is what our shared goals are for improvement and what we know clinically and what patients are bringing to the table, which is their values, their interests, their goals, how we can work together. I talk a lot about evidence. Evidence is really important to me. I'm a researcher. I love it. I know it's weird and nerdy, but that's just where I stand, mostly because I think it helps me to be more confident when I'm talking about these things with patients. And I certainly don't expect patients to go back to original journal articles, but I certainly encourage providers to do that. I think some of the problems with overprescribing in the past have been related to sort of reading research summaries and thinking that we understand a topic and imparting that wisdom to patients when we really didn't have a firm foundation clinically. We want to be able to summarize different kinds of evidence for patients, not discount research that doesn't align with our own belief system about something. We need to be flexible and willing to learn new things. These are the screening tools that we use for population health in my practice. I know, in particular, I'll mention the PC-PTSD screening tool for post-traumatic stress. I know a lot of people do ACE scores. That's just a very different kind of information that you're going for there. What I want to know with these tools is what is going on now with this patient. What symptoms are affecting their care? And really, one of the things that Neil mentioned is having a willingness to sort of setting the stage for future conversations. This first conversation with patients may not go great, and often it doesn't, and I tell providers that all the time. Your first meeting with a patient, when you're talking about shared decision-making with opioids, they may feel really frustrated because they may have come in thinking that opioids are the only thing that's helpful. When we do these screening tools, and in my primary care practice, we do these 5 tools with every patient on any controlled substance, including stimulants and benzodiazepines, which are a weighted topic for another day. It just gives us more information and often kind of an opening to talk about these underlying issues, how pain is affecting patients and how their history and their mental health symptoms are affecting their pain. Often patients are concerned that by giving them these tools, they're afraid that we're saying that we think it's all in their head. And what I explain to patients is, you know what, a lot of it is in your head, and what's in your head is your brain, which is the most complex organ in your body and is, inseparable from every other system that you have. So of course it's important to know what's happening with someone's mental health. Accountability, measurability, again, these are just ways of keeping us consistently on track. This is some scripting that we use. So I'll talk a little bit about the model that we kind of designed after I did this shared decision-making project through Maine Quality Counts, which Dr. Corson was a consultant on and very, very helpful in kind of figuring this out. And in the beginning, it was overwhelming. This was around treating major depressive disorder, because there were so many tools and technological options, and it's so hard to get anything like that implemented in primary care. They're super overwhelmed, and the electronic medical records are limited. So what we came up with is what we call a quick text, and some people call them macros. Basically, it's a pre-populating, setting your medical record to with a click of a couple buttons, pre-populate a phrase. And the way we do it is pre-populating documentation. This here is about setting the stage. So when we're starting this conversation with patients, I offer a lot of scripting to providers. I thought back not that long ago that they would find that insulting. They don't. They are certainly not going to repeat this verbatim, and I have certainly stressed the importance of looking at research so that they can really believe what they're saying, because that makes all the difference. It has to be a genuine interaction. But just being able to simply explain that opioids relieve pain by working on the opioid receptors in your brain, and the same process that helps with your pain also triggers the pleasure center in a way that makes it hard to stop taking opioids once you start. That's a non-blaming statement. We're saying, here's the situation people are in because of this. This is what happens neurobiologically. Now where do we go from here? And furthermore, when you have a positive PC-PTSD screen, which is the primary care post-traumatic stress disorder screen that asks about symptoms of PTSD in the past month, we can say that people have been through something extremely scary or who have been through something scary or life-threatening can have changes in that part of their brain that makes it even harder for them to stop taking the prescribed opioids. I am an integrated behavioral health provider. I lead a program. Whenever anyone talks about a healthcare crisis or issue, my answer is always integrated behavioral health, not because I think they all need to see a psychiatric provider, but I think that medical administrators and providers really need to incorporate some understanding about mental health and behavioral health into their own practice with their own patients. These are just ways of talking that integrated behavioral health can help, and I've already talked about a lot of this. So now I will talk about the quick text. This is one of the questions that I got from a number of patients and that providers said they were really struggling to answer with their patients. We're talking about tapering, high-dose opioids, which we know are a risk for overdose, respiratory failure, and really just, even when that's not the case, that they have people, addicted and dependent on medications that they're unable to stop. So you've been prescribing this to me all this time, and only now you want me to stop? What happened? This is a lot of this information we include in a quick text in the EMR. Not in exactly these words, it's a little wordy, but this is about how to talk about this with patients. So saying, we care about your health, your quality of life, and our community. Now, just as a preface, I want to say that what I had been hearing, some primary care providers having these conversations saying, were everything from, there's a new law in Maine, I'm going to lose my medical license if we keep doing this, so we've got to stop this medication. Or I'm going to retire in a few years, no one else is going to give you this, so we've got to stop this medication. Patients don't want to hear that. I mean, you may end up with the same result of tapering patients, but you're not aligning with the patient. There's no shared decision making. They're just being told, look, this is how it is. This is an alternative way of approaching that. So decreasing or stopping chronic opioids can improve your quality of life, functioning, and relationships. We will be working with you to find safe and effective alternatives to high-dosage opioids. We know this will be a challenge, but we are ready to partner with you as we make this change together. And the other question, what else can be done to help my pain, and will it be as effective as current therapy? Again, this is an entirely different webinar, but we know that there is research to support lifestyle changes, like changes in diet and exercise, affecting not only depression, but also pain and anxiety, medication options that target multiple symptoms and conditions. And I talk a lot with patients about shortening their medication list when they're on these 30 different medications. We don't know what their symptoms are and what's a side effect or interaction from one of the medications. In this case, we talk about medications like, gabapentin or Cymbalta, medications that can work on anxiety, depression, and chronic pain, depending on the type of pain. Medication-assisted treatment is Suboxone and methadone. What the evidence tells us now is that the best, most effective combination of medication or treatment for patients with a combination of opioid use disorder and PTSD is cognitive behavioral therapy, which I'll talk more about, and Suboxone, or medical assistant therapy. This is how patients often respond. I tried therapy, it didn't work. Often patients will say, well, I sat on this couch, I talked about my week, it felt good while I was there, but then I left and nothing changed. This is a quick text right here. So when you type into our medical record .cbt, this is what comes up. Here. So for documenting shared decision-making for prescription opioid use disorder, provided information about treatment options for the diagnosis, including risks and benefits of lifestyle changes, therapy, and medication options. So this does not replace the shared decision-making process. We use these quick texts as a prompt. Primary care visits tend to be 15 to 20 minutes long. There's a range of incredibly complex issues to address. Patients will often mention something as the provider's walking out the door. We needed to make this as quick and accessible as possible. What this does is it prompts providers to have this conversation with all of their patients. And again, documenting shared decision-making for people with prescription opioid use disorder and post-traumatic stress disorder. This, again, is a prompt, and they can put this in their documentation, and it also is prompting them to do it. Provided information that research finds a combination of CBT and medication-assisted treatment is the most effective approach to improve outcomes for people with PTSD and opioid use disorder. Now, a patient may say, I don't want that. I don't want to do that. We come back to the shared goals and come up with a plan for what will work, but at least we're providing evidence-based information. I say what to print because I think it's really important that patients go home with printed materials to look over and discuss with their families. These are often big treatment change, emotionally charged conversations. We want patients to be able to review this, to call with questions, and we want to make sure that when we're documenting not just what we said and what we want, but what the patient said and brings to the table, and that there's a brief, accessible, understandable, and clear treatment plan with a few key points, and those should be the goals that we have agreed on. These are the things we're going to work together to achieve. How can behavioral health providers help on a systems level? I work a lot on policy with medical organizations, just having a behavioral health voice at the table, either at small practices or at large healthcare organizations. I think it really does help inform the work that the medical providers do with these patients. And that is, I have many references, and as I said, I love references. There's more accessible and available through the moderators here if anyone needs them. And I am going to pass back to Melody. Thank you so much for the opportunity.
It was really interesting to me, Jesse, I'm sorry about that, when you were presenting the conversation that was taking place in the participant chat, because the comments were so hand in hand with what you were speaking about, the looking for options to involve different ways of managing pain other than medication. So, for instance, someone mentioned using occupational therapists and other disciplines so that we can help people shift from the focus on medicine. I'm wondering if you or Neil could comment about how you loop in other professionals.
Well, I mean, I can comment just in my own experience. I think it needs to, because I work on an integrated behavioral health team, or an integrated primary care team, I work often and on a daily basis with clinical providers, patients, families. We did a chronic pain management pilot, and I included my medical assistant in that. So we work together within the practice. On a broader level, I think that it's really helpful to have a behavioral health voice and leadership meeting so that administration understands the importance and what behavioral health brings to the table. I don't really think they necessarily know until they see how the conversation changes when that voice is there.
Thank you. All of the professionals together at the same time, I think, is critical. That the leap to improving and streamlining communications somehow seems to be one of the biggest challenges.
Can I'll make one comment, this is Neil,
Yes.
which is that I think many of us are aspiring towards, I'm not sure how many of us have achieved this yet, but aspiring towards a shared patient-centered care plan, and that as we increasingly work as teams, which we have to meet the needs that people bring to us, having a common plan that the patient, the client, the person we're serving is actively participating in creating includes their preferences and their goals for treatment, keeps all team members aligned in terms of providing services that are consistent with what the person wants.
Mm-hmm. Mm-hmm.
So I think shared decision making fits into that larger goal of a patient-centered shared care plan.
Yeah. Neil, while I have you here, another question from one of the participants has to do with how widespread shared decision making is, and I'm wondering if some of your work has allowed you to get a sense for how shared decision making is moving within general health care, and if you have any insight into how it's spreading through behavioral health care.
I don't have a lot of insight other than, as Jesse had mentioned, that as part of Maine receiving a state innovation model grant, there was a limited pilot. It lasted less than a year, but 3 behavioral health organizations, including Jesse's, worked on it, and at some level or another, I think, have at least sustained the principles, if not all of the specific practices that they were piloting. I think shared decision-making, I've looked around the country to find the best performers, and I'm afraid we're still at a point where there are islands of excellence of people who are fully committed to doing this. I think there's likely an increase in engaging people more actively in making decisions because of all the attention to shared decision-making. In terms of standard, routine, day-to-day care that includes the active use of decision aids, I'm not sure we're too far down that road yet, but I know a lot of people are at least at the talking about it stage.
I agree, and I just want to chime in that I think that what really changed really was an aha moment was when I came in doing that pilot with a whole, binder full of plans, as I am wont to do, and references, and Dr. Corson kind of said, you know what, maybe you're going too big. maybe simplify. And when I did that, and the way to sell it really in primary care, because a lot of us are using at least the interventions that I've talked about here, is to make it simple, easy, accessible, and something that can make patient visits in primary care more efficient. So you can sell it to the providers as this is going to take these difficult conversations and make them go more smoothly. And it truly does. And they see that, and then I think that's the way to get it spread more widely.
Yeah, that sounds like a solid approach. Another question that we've seen is some of the resistance around time and cost when utilizing shared decision making. That it takes too much time, which then, of course, means that it costs something. How do y'all manage that in your work?
My interventions don't cost anything. they're already established in the EMR in a function that is already there. these are patients who come in for 20-minute visits with these difficult conversations, and they end up taking 45, 50, 60 minutes. Providers end up documenting at home, late at night, getting calls on call by patients wanting opioids, for whom those opioids were never really treating, anything to begin with, or were treating something that they're not particularly effective for. So I think we use what's already there and work within the framework we already have, and don't try and develop a whole new infrastructure, and then just pilot this on a small basis. And what happened to us is we did it in our little practice, and all of these other practices said, wow, what are you guys doing over there? And they started coming to our meetings, and we showed them how to do it, and it's, maybe slowly, but it's definitely spreading.
Yeah.
I just want to add that the research has looked at the time impact of shared decision-making. Again, research studies are more controlled than the real world of taking care of real patients. But in the research that's been done, sometimes shared decision-making increases the amount of time that a face-to-face visit takes. Sometimes it actually decreases the amount of time because it's providing structure, let's say, to a conversation that's going to happen anyway. This is another situation in which using the team and thinking about which members of the team can do what components of the process may be the right approach to avoiding, certainly providers can't afford to spend lots of time, and the more prepared a patient is, the more streamlined that aspect can be. But it's also true to say that making a good decision can save time down the road compared to making a bad one.
Absolutely. That's where I was going to go with it. That in a lot of ways, shared decision-making is an investment in time. I'm sorry to say that we are out of time for this webinar. I really want to thank our presenters today for sharing your thoughtful comments, your responses, and the expertise that you have that you've graciously shared with us. For further information about them or their work, here's their contact information, and I'm sure that in their bios you can find other ways to link to information about them. The other thing that I want to be sure and let you know is that this is actually just the first of a series of 3 webinars that are going to be discussing shared decision-making for the next 3 weeks. And so if this has just whet your appetite for this subject, I hope that you will join us. You can register for these webinars at the RTP website. We are also going to be doing a Learn More webinar on psychiatric advance directives in early October. If you're interested in NADAC continuing education hours, please click on the NADAC link that you see here on your screen, and you'll be directed to a page with an evaluation and a quiz to complete to receive your certification. If you're not interested, you still can download the certification of participation, which is quite helpful when you are looking for CEUs for other disciplines. You'll also be given an opportunity to complete a feedback form regarding this webinar and the series as a whole. We really value the input that you're able to share with us. On behalf of SAMHSA, I'd like to thank you for taking the time out of your day to attend this webinar. We appreciate your interest, and this now concludes our call. Have a great afternoon.